Next, we have Dr. Rahul, and he'll be talking to us on retinal pigmentation, benign finding or life-threatening clue.
Can I have a slide? So good morning, everyone. At the outset, I would like to thank Dr. Shishir for this, including me in this instruction course, and I'm happy to see so many audience still up even after the post-banquet. So I'll be talking about retinal pigmentation, a benign finding or a life-threatening clue. Now, why this topic? Now, suppose a patient's come to you, a toxoplasmosis affecting the macula, and you see the patient and you want the patient for a system, send the patient for systemic evaluation. When you convey this to the patient, it feels justified. The patient is ready to accept it. But many a times you see some lesions in the periphery and you don't know what to do. And sometimes it might be a sign for something very sinister. And that is how when you send these patients out for a evaluation with a intensivist or a physician, that's when you should have a very good clue idea about what lesions you can just probably sit on it, and some lesions which require a detailed evaluation. So I'll be talking about certain lesions like that. So the first thing is congenital hypertrophy of the retinal pigment epithelium, that is CHRP. So it's basically a hematoma of the RP. There are three variants: the solitary form, the grouped, that is multifocal, and then you have the atypical and multiple. Now, in the subsequent slides, I'll tell you about what is the difference between multifocal and multiple CHRP. So this is solitary CHRP. These are usually appear as a flat, round hyperpigmented lesion. They have a smooth margins. The usual size is around 100 microns, or it might be larger. They are well demarcated. The overlying retina and the vasculature is absolutely normal. They have a predilection to be for the superior temporal equatorial region, and this may enlarge over a period of time. These are group CHRP. These are also well demarcated round lesions. They are around 100 to 300 micron size. They are called as the bear track lesions. And when you look at these lesions, the size of these lesions will increase as you see. These are group ones, right? So from the mid periphery to the periphery, you will see that the size of the lesions will actually increase. And they are usually grouped in a bunch of 3 to 30. Now, when I talked about the multiple one and the group CHRP, how is it different? So in skin, there's there's something called as a line of Blaschka. That is what happens is there's an embryological developmental of the skin. Just like similar to that, you have a embryological development of the RP, and that is why in the group CHRPs, the lesions will appear grouped in a particular segment. Now, when you look at the multiple CHRP, they might be haphazardly distributed anywhere over the fundus. So these ones are usually smaller than the solitary as well as the group CHRP. They will be around 50 to 100 microns in diameter. They will have retinal invasion. You will see glial or capillary or RP hypertrophy. And some of them may also appear as a typical shape, that is the pisciform one. The pisciform one, that is the one in the top down right side of the picture. You can see a pisciform kind of CHRP, and they have meritonal orientation towards the optic disc. So why is CHRP important? Because most of this, when you see this atypical or multiple CHRPs, they are associated with the familial adenomatosis polyposis, that is FAP. So these are inherited, highly penetrant genetic condition. If a patient has familial adenomatosis polyposis, they have literally 100% risk of a colorectal cancer. And patients with a typical multiple CHRP, almost around 90% of these patients will have this FAP. Also, along with this, they are also associated with Turcot syndrome and Gardner syndrome. So, what is Turcot syndrome? That is, you have a familial adenomatous polyposis with the brain tumor lesions. So, they have a higher risk of colorectal cancer, glioblastoma, medulloblastoma. There are two types. There's a type 1, which is germline mutation in the DNA mismatch repair genes. And in the type 2, you have a germline mutation in the APC gene, that is chromosome 5. And then you have the Gardner syndrome, where you have features of familial FAP with extracolonic manifestation, that they'll have higher risk of skull osteomas, thyroid cancers, fibromas, and desmoid tumors. So whenever you see patient with CHRP, that is a typical, if you see a solitary CHRP or maybe a group CHRP, probably you can reassure the patient, but keep the patient on a follow-up. Whereas if you see multiple or atypical CHRP, refer the patient to a gastroenterologist. Not just a systemic problem. This is a case from Carol Shields, where you can see in the top left image, there's a patient of a solitary CHRP, which over a period of time developed a tumor, enlargement in size. And when they did a enucleation, it was found to be an adenocarcinoma of the choroid. And not just systemic issues, they can sometimes also be associated with a development of choroidal neovascular membrane. Next, this is congenital group alpinotic RP spots, that is CGARPs. So, just like the bare track appearance, that is the CHRP, which is pigmented black, this one will be white. So, these are called as polar bare tracks. They usually affect the peripheral retina, and usually the macula is spared, and it can be either unilateral or appear in both the eyes. So, in this image, you can see in the color picture to the left, you can see all these white spots, which probably most of us would have seen and probably not given a second thought to it. So nothing to worry, you have not missed much. And if you get a autofluorescence for this image, you will see it as a hyper autofluorescence. So when you get an OCT through this lesions, you will see that the RP in that region is a little thickened, and you might sometimes see some RP excrescence. The vessels and everything overlying retina will be absolutely normal. So this is a completely benign lesions, and you don't need to hit the panic button. And then next you have the choroidal nevus. So they are basically benign melanocytic lesions of the posterior uvea, and you can have two variants. You can have the pigmented lesion, pigmented nevus, as you see in the left side, and you can have the amelanotic version. Now, if you see a nevus, okay, fine, keep a tab over it. But there are certain times this nevus can have a malignant transformation, that is into choroidal melanoma. So we usually have this mnemonic to find small ocular melanoma using helpful hints daily. So whenever you see, if the nevus has a thickness more than 2 mm, if there is a surrounding subretinal fluid, the patients come with symptoms of flashes or floaters. If you see orange pigments over the overlying nevus, then yes, you need to hit the panic button. If the margin is within 3 millimeters of the optic nerve head, on ultrasound it appears hollow. If there's a halo absent, if there's a peripheral halo, that means it's a sign of chronicity. And same way, if you see if you see a nevus with drusen, you can rest assured that it is a very chronic thing, and you don't need to worry much. And this is another important pigmentation that you can see, that is called as the leopard spot pigmentation. Dr. Risha had already shown on picture. So this is the picture that you usually get. You will see multiple white spots. The patient might have some amount of vitritis or something like that. The first thing is what we tend to think is it is probably a case of uveitis. And as we know, most of the uveitic conditions, it's an inflammatory condition, and the treatment that is required is steroid. You have to really understand that there's a differential of a posterior vitreous PVRL, that is intraocular lymphoma, which also appears similar to like this. And what happens is, when you give steroid and you take a biopsy from this lesion, the biopsy, because we have seen a case during my fellowship where a patient was treated as uveitis. Finally, it turned out to be leopard skin pigmentation, PVRL. And what happens is, when with the steroid, the biopsy comes negative. And as long as you have the tissue negative, the oncologist will not start the treatment for that. So finally, it ended, we had to stop the steroid treatment, wait for a couple of months, and then take up the patient for a biopsy. And only then the biopsy, treatment for lymphoma was started. So you should have a good idea about all the differentials of these pigmentations. So my take-home message would be, not all pigmented lesions are dangerous. A good knowledge about them is very essential. Reassure, but never keep them out of sight. And if you see an atypical multiple CHRP, refer the patient to a gastroenterologist. Thank you.